right, guys, welcome back to another episode of the Fill Me In podcast. I'm Injector Jon.
And I'm aesthetic nurse Nicole.
And we are going to be diving deeper into the world of aesthetics, but also wellness today, right, Nicole?
Yes, so we are very lucky. We have our wellness clinician, Megan, here with us. Megan, go ahead and introduce yourself.
My name is Megan. I am the wellness provider at Exhibit Medical Aesthetics. I formed the Exhibit Wellness part of the office. So I have a DNP and a BSN. So I am technically a doctor of nursing practice. I'm an FNP, so I have a family nurse practitioner certification, but I don't go by Dr. Meg. I just go by Megan. And yeah, that's why I'm here today.
Yeah.
Love it.
And I
Megan,
love that.
Yeah, Megan's worked so hard building like this incredible wellness basically practice that we have now as part of our med spa. Megan, kind of go into, what we offer.
Sure. So I've been with Exhibit for a little over a year now, and I know I met with you guys probably a few months into helping form this practice, right?
Yeah.
So a lot has changed in the last year.
Yes, part two, exactly.
This is the ultimate revenge, right? We get to say all the things that we wish we said the first time. And so much has changed. But in the last year, really what we focused on, or what I focused on in conjunction with our medical providers, the practice was understanding what our clients' needs were, our patients' needs were. Obviously, our most common patient in aesthetics is are females, right? In their midlife age, men too, of course, but part of what we do is we identify what the patients need, right? And we get feedback. And what we really started to realize is women don't receive this type of care in insurance-based medicine, and they don't want to be treated like they have to hand out a credit card every single time they come, especially with anything like hormones or weight management. So these are the two things that I focus on. We've developed some programs as a result. And originally, everything was, hey, when you come in, there's an appointment fee. We've really gotten away from that, right? So the way that we've changed is we funnel everyone in through a general consultation, because you should never see a practitioner who's not willing to do a deep dive into what's bothering you. And then we offer tailored programs now, right? So if I believe a program is better suited for you based off of weight management versus hormone management, maybe you're postpartum, maybe we think you have a little bit of PCOS, right? Or you're a male looking for hormone optimization. You should not be treated the same way as my postpartum patient. And I think that's why in this type of care model, we can do that, right? Where in a traditional office, you go to your primary care office, all they know is your chief complaint. And maybe not even that. If they don't have a chance to look after their 10, 20-minute appointments, they're basically walking in and saying, what can I do for you today, right? And you only get one complaint. As soon as you start listing more than one,
another appointment. Yep.
Exactly. So I think we've changed that a lot in the last year. And even just building off my experience working at other practices, but also doing my clinicals, that was something I found was really important. And it's really emerging right now as a really popular industry as we've started to notice the blend between aesthetics and wellness. But I think it's really important to differentiate between wellness as a marketing term, right? And understanding the difference between licensed clinicians and health influencers, right? And health coaches. And it doesn't mean there's not a time and a place for them, but there's a certain person who writes prescriptions and gives official medical advice. And there's your influencers who can give you guidance, right? Or information about a product or review about a product, but under no circumstances should they be giving medical advice or writing prescriptions. So
I feel like
really
we're
important.
really like in this new wave of wellness, and just because I think the biggest barrier for women in family medicine is sometimes they feel like they're overlooked, especially in their late 30s, 40s, 50s, early 60s, right? That peri, postmenopausal symptoms. And I think over the past 2 years, there's been such a surge in people seeking hormone replacement therapy. And I do think that maybe the GLP-1s, the peptides that had came out, kind of pushed that a little bit, that more awareness. And I think, like you said, I think there's people like yourself that have maybe like focused a little bit more GLP-1s initially, but now are broadening into hormones because there's so much that goes into that as well, into making you feel good on the inside. So do you agree?
So it's interesting you say that, and we haven't even talked directly about this in over a year now, but that's exactly what happened to me. So just a deep dive into I started in the cardiac telemetry as a nurse, then I went to emergency medicine, right? And yeah, you're just trying to put out fires there. When I started doing my clinicals as an FNP, I followed doctors and I followed nurse practitioners and PAs, right? And I was seeing the same theme over and over again. Like I said, when I really started to notice the difference was when I went into the aesthetic space for the first time. I was in a practice where I was really the primary mid-level. So there were no other PAs, no other NPs. And I noticed I started doing a lot of weight management with GLP-1s. It was when they first blew up, for lack of a better term, right? 2022, around that time. So every single patient was coming in. I was like, wow, this is great. I am really helping women. And I slowly gravitated away from aesthetics and into specific weight management because that's just what called me. It felt very familiar to me and I felt very comfortable with it. I needed to pick. I had the niche down.
And what were you noticing with the GLP-1s? What were they helping women with?
So I noticed a lot of women, they would immediately say within the first month, even if they didn't lose weight, 10 out of 10 times, I noticed that I don't feel as puffy. And it sounds terrible, but I don't feel like a sausage in casing anymore. And we would laugh because I never, there's you have to be so mindful of how you speak about weight. But every time they would gesture to their midsection, but I felt like I would hit a wall, right? You'd hit a plateau mentally, but also physically. And every time I'd say, I just can't seem to get on top of some of these other symptoms like difficulty sleeping, mood swings, right? Menstrual changes. And I was like, I'm missing something here. And I don't feel that I can figure this out by, quickly looking over the weekend. And I started, definitely my algorithm worked for me. I started connecting with other practitioners who mostly were women, right? Female practitioners who were doing a lot of hormone management and doing a lot of menopause management. And if I didn't find those women on social media, those clinicians, I don't think I'd be where I am today. I mean, it goes hand in hand. Beyond what studies show us, we see studies of patients who use GLP-1s and hormone therapy, they do better. Right? Not only with weight loss, but they just feel better. And I do think if you're solely out there just trying to offer weight management, but you're marketing yourself as more than an obesity medicine practitioner, you're letting people down, right? It is one of those things where I think every clinician should have training in menopause management. Everyone's going to reach menopausal age if they're a female and they live past their 40s, right? So it should be included in education.
And they need to be more comfortable having that conversation because there's so many women, and especially I know you, Nicole, and I'm sure you, Megan, have seen this in your practice. Like my patients are like wanting to leave their current doctor to find maybe a young doctor that's up and coming because they're so well versed now in this new conversation that's happening in wellness that they want to make that switch over to someone who will take the time to talk to them.
Yes. And I think it's so important to make the distinction, like even me, and I'm introducing myself as an FNP. I do not intend, and I sound like a broken record in the office, but I don't intend to replace your OBGYN, right? There's a need for them, right? I'm currently not doing pap smears and pelvic exams, right? I'm not delivering babies. I'm also not necessarily, I am a little bit now, but I'm not doing Medicare wellness visits, right? Or doing a lot of that chronic disease management other than weight management and hormone management. There's a time and a place, and I'm emerging as this person that is bridging the gap. So let's see, they see their OBGYN, they bring it up, maybe they get pushback. They don't feel empowered, like you said. And then they end up in my chair. Maybe they mention to Nicole or Melissa or Gab or Cami, one of our injectors, I'm just not feeling great about myself. Or they'll see one of our MAs who are working with me and they're like, you look fantastic. What are you doing? The beauty of, women and men who have that community feel and are feeling comfortable in an environment is they're more willing to talk about it and be vulnerable. And I really don't think that would happen in a starchy, typical medical practice. You feel intimidated, right? And it's very uncomfortable to talk about dryness or I have no interest in intimacy. And that doesn't just affect women. It affects all relationships. And it's something that should be talked about.
And I think people are willing to pay a premium, right, to have that conversation outside of a doctory feel office, like where they feel more comfortable having that one-on-one. You know what I'm saying?
And let's be real too, right? Like if you are going to a doctor's office insurance base, they have about 15 minutes with you.
Sure.
So especially if it's a physical, right? If it's a physical, they're going to do, go over the important things. And then when you bring something like that up, they're probably going to be like, unfortunately, we're going to have to do another appointment or brush it off and be like, nah,
Right.
And it's so important. And that's where I really try to choose my words. It's not anyone's fault. It is truly the system, because I witnessed it myself. And yes, not everybody thinks that stuff's important to talk about. But I do genuinely believe that as clinicians, most of us went to school and got a degree and a license to care for people. Right. So I don't think it's in their best interest to say, you know, I don't care about this stuff. I don't want to do this stuff. They're seeing, like you said, by the time they get in there with the MA and the MA's out of the room, they're in there for 10 to 20 minutes. They have to literally put out fires and triage. What is the most important right now? And they're using their codes, right? Their billing codes. I explain this to patients. They're using CPT codes and ICD codes to basically dictate whether or not it's going to be a worthy visit to the practice. And that's so devastating, because I do think a lot of practitioners wish that they could go deeper, and they can't. They're, you know, they're going to get dinged one way or the other, right? And that's where we've all emerged. I think it's so important, though, to know where you're spending your money, because we're not cheap, right? What I love about what I do, similar to you and Jon and other injectors, is we provide quality care, and we don't feel that we have to rush the patient in and out. Why are we able to do that? Because we're not using insurance as a middleman.
Let me tell you, I remember being in FNP school, and like, you know, you learn how to chart, you learn how to code, and putting the codes in. And my instructor was like, you can't put 60 minutes for a physical. And I'm like, but I was in there for 60 minutes. And she's like, it'll get denied. Like, you cannot put a 60-minute visit. I'm like, but it was a 60-minute visit. Like, so that's why they physically, like, they don't do 60-minute visits, because insurance won't cover it. Like, it's crazy.
It's actually scary.
Hey everyone, it's Jonathan, also known as Injector Jon.
And I'm Nicole, or Aesthetic Nurse Nicole if you follow me online.
We are so excited to let you know that we've launched our Patreon.
Yes, it's on there. We'll be sharing exclusive content you won't find anywhere else, our own injecting techniques, advanced education, and even some behind the scenes business advice.
If you're an injector, aesthetic professional, or just curious about the industry, it's the perfect place to learn and grow with us.
So head over to Patreon, search for us, and make sure to subscribe to get access to all that extra content.
And don't forget, you can find me at Injector Jon.
And me at Aesthetic Nurse Nicole. We can't wait to see you there.
Love you guys.
And Jon, that's something that we kind of, I've built in the last few months leading up to 2026 is I kept running into the same patient. It was a male or female in their 20s. They're coming to me. They're like, hey, Megan, I heard about you on the podcast, or I heard about you from one of the girls in the office, or my friend came to see you and you did a deep dive into their blood work. I want to do that too. Can you send me to LabCorp? Can you use my insurance? And the first thing I say to them is, luckily for you in the state of New Jersey, they protect the consumer. I do not profit off the labs I order for you, but I can guarantee if I order it through LabCorp Quest and use your insurance with the long panel that you're seeking, I cannot guarantee what that bill is going to look like. And I can almost promise you your insurance is going to deny it. And now it's going to be stuck on you. So trust me when I say, pay the cash lab that we have preset. It's very transparent. Every single lab is listed as an item on the invoice, and we don't have to stress out over whether or not you're going to get $1,000 bill later on, right? So if you want that deep dive, you have to be okay with shelling out. I don't know, my lab panel is a little over $200, not including the consultation fee. And I think that's pretty reasonable, right? Given we're risking going to LabCorp Quest. I'll do it. It's no skin off my back. But now I can't promise you're not going to get a large bill after the fact.
And I can attest to that. So Megan actually follows me and my husband and lab work and all of that. So Kevin wanted to draw a bunch of different labs, and she was like, I really think we should go with Rupa, a cash pay, because you have no idea what they're going to come back and cover. So we did Rupa for him. And then because mine is thyroid and things like that, and we have codes for it, we ran that through insurance. So my insurance covered everything but like $20. And we drew, I don't know, maybe like 2 tubes on me. And it came back as close to $1,000 what insurance covered. And then Kevin we drew 8 tubes on him. We sent it to cash pay. He paid $250. And
Kevin did more than I even do in my panel.
And it was $250 cash pay, but had we sent it to LabCorp and they denied it, he probably would have been on the hook for at least $1,500. You know, so it's just, if you're a patient listening, like $250 might sound like a lot, but compared to $1,000, you know, it's not, and you don't want to rely on your insurance and then be stuck with a big bill.
And I hear from other places in my area that do wellness that, I mean, some people are spending like $800 a month, or they're spending, or 6 or 8, you know what I mean? On like, they pay the office like an office fee.
Fee,
And
yes,
then
yep.
they, prescribe their medications or do whatever, you know what I'm saying? But
Yeah,
people will do it. They will
right.
do it because they feel better. And yeah.
Yeah, it's worth it. Well, Megan, do you
Worth
want to, this would probably be a good time to talk about. So obviously Megan's been with us for a while now. And in the beginning we had the compounding, then we lost the compounding. So there was a lot of changes that we had to make. And Megan's put so much work into figuring out what people want and what works for people. So we recently just made like a big menu change, and maybe she could touch on that, because we kind of steer away from even like, we don't want monthly payments. We want you to feel like that care is there. And I guess, Megan, you can explain it better.
Yeah, absolutely. So to touch on the compounding conversation, we went from using mostly compounds, right? Part of that was because they weren't available through the brand name pharmacies, right? There was no availability, right? So a lot of us were using compounds, and I liked them. I loved the customization of the dosing. It had a little bit of B vitamin typically, or other vitamins, and most patients were deficient in them anyway, right? So we're preventing multiple injections a week for one purpose. And then it became more commercially available. Even further, they started offering a similar item. So one of the companies, Eli Lilly, offers Zepbound in vials. So that has become my drug of choice. And it's not that I have a problem with Novo Nordisk or semaglutide. In studies, we know that patients in the Zepbound arm or the tirzepatide arm did lose more weight than the patients in the semaglutide or Wegovy arm. So they do lose more weight. I tend to find patients have less side effects, right? And the main thing I care about is that dose appropriate for the patient? Because Jon, I'm sure you guys see this too. If that dose is too high, this is 1000% where those negative side effects are coming from, along with the nutrition and speaking with a clinician who actually is giving you that feedback. So I like the vials, because if someone can't tolerate that full dose, we don't have to anymore. Where the pens, patients are being told, shoot it in there and pull it out halfway. It's like, what are we doing? It's just gotten wild.
I've never heard of that.
It is like, patients were literally being told, dial it up, push the button, and then pull it out after 1 second. Yeah, to make it work. And so there's a time and a place. So I've steered away from compounds. Not completely. I'm not going to sit here and say I don't use them from time to time. If a patient is deficient in B12, maybe they have a gut issue like a Crohn's or an IBS, or we know they have an absorption issue, right? A lot of our celiac patients. Or they do really well with, I don't want to bring up microdosing, that's a whole tangent we could go off of, but if someone benefits from using this medication off-label in terms of how often they're using it, whether it's twice a week, right, in smaller doses, there is a time and a place for using compounds, just as there's always been. I think we kind of went off in a tangent because patients were being told this is better, this is safer, right? Or it's only this 100% of the time. And just as you guys know, you've got your menu of fillers, you've got your menu of toxins, you've got your menu of skincare. It should never be one size fits all. And I think we got so tunnel vision with only compounds or only brand. It's like, take a step back, use your clinical judgment. If insurance covers the medication for a patient, or if they need that extra B vitamin, use it. It's used as a tool. But the program, like what you were saying, Nicole, I tried to get away from the monthly payments, because I still think a lot of patients get confused about the non-insurance model, right? And I don't want them to feel like every single month that they come in, they're being charged for something. And I've also noticed a trend, and Jon, I'm sure you can attest to this as well. Nobody's sticking with this for 3 months. Everybody's in this for the long haul, which I love. Patients are really starting to understand this is not a quick fix. I don't care if your body fat percentage is just a smidge over what it should be. You're still not going to start and stop this aggressively. And it should feel like a journey, not this sprint of my wedding's next month, I need to lose 20 pounds. Don't even bother,
well,
right?
And plus they are on it. They feel how good they notice how good they feel, on it. You know what I mean? Okay, Nicole, that was an aggressive little.
Oh, sorry.
I'm just kidding.
You know what I'm used to? I'm used to having the mic, so I'm like, I'm over here, and I'm probably right next to the computer microphone. Sorry, everyone.
No, literally, I was like, I'm going to start laughing.
I'm so sorry.
I'm like, you twirl that matcha, girl.
Oh my God, I'm so sorry. It all settled on the bottom.
But people notice how good they feel on these once they start it, and they don't want to get off of it. And I think, for me personally, my personal journey, I've tried Zepbound I had side effects to it, which for me, it was just too much rapid weight loss, which I don't need because I'm a string bull or a string bean. I also had, and I'm very transparent, I had the runs with it. Like literally it would happen for
He would call me
3
every day, be like,
straight
"Hey, I'm on the toilet."
days. I go, do I have norovirus or is this Zepbound? I really don't know. Because it would literally be like out of my ass for 3 days, like I was taking a Go Lightly prep. And then I kind of went through it, and then I'm like, okay, I need to be on this for my high cholesterol because it really helped to lower my cholesterol by 70 points. So I switched over. I talked to my husband. He's like, all right, let's just switch you over to Wegovy. And I went over to Wegovy. Previously, I had issues with constipation with Wegovy because obviously it acts more in the GLP-1 with slowing the gut. But since switching, I'm actually doing good, and I've increased my fiber intake, and I'm doing much better. Like I'm like,
see, but that's a perfect example of it's a big red flag, and I love the parallels right now. If you go to a provider who says, we only offer this brand of filler.
Yes.
No, diversity, right?
Yes.
No, diversity, that's a very good point.
Yes.
It should never be, I only use Zepbound for every patient, right? How do you know it's going to work for that patient? And I'm not trying to attack, right? But if you're only so confident in one modality, then you need to branch out and get comfortable with other modalities because true and don't even get in like the whole drama with the insurance. That gets a little confusing. I will use insurance for your medication, right? So office wise, you're paying me for an annual membership. That means when you come in the door, don't whip out your credit card. You get perks, you get supplement credits, you get a percentage off our other services, which we find to be complementary to what you're doing. But any office visit, we built in some sick visits, body scans, vitamin injections. Put your card back in your bag. You're already in, right? You're in with us for the year. I cover 2 lab draws for them, so they can come in and I can draw their blood, or they can go to LabCorp requests, and I will use that once they're established, right? I have the ICD-10 codes. If they want to go really in depth, we'll go back to Rupa and we'll do the big panel. But for medication, I'm happy to use insurance for your drugs because medication insurance, which this is a learning curve for a lot of patients.
Yes. Yep.
There's a drug insurance and there's a medical insurance. And for many patients, it's not on the same card. It's like, so I'm willing, sometimes, Jon, you might be like, I really want to try, like in your experience, Megan, what's the best medication? I might tell you, personally, I'm a Zepbound girly. But I'll be honest with you, if insurance tells me that they will not cover it until you've tried Wegovy for 3 months, I can try to fight it.
Sure.
But we might, if it's important to you that we try something now, I might have to put you on that and we'll give it our best bet. That's why you need the body compositions, right? Because I can go back and say, all right, Jon has come in every month. He's following his nutrition. He's following everything he's supposed to be doing. He's doing the lowest, most effective dose for him. And he's not seeing that percentage change in his weight.
And that's the thing for me is when I was on the Zepbound previously a year ago, and I tolerated it really well for 4 months. And the hunger noise, I cannot get over how I had zero noise to eat.
That's crazy.
Like it was on the lowest dose every other week. I'm like, this is insane. And it actually help my anxiety. I realized I actually had like hunger anxiety. Like if I was stressed out, and that was before I was on an SSRI, but like when I was more stressed out, I would want to eat. I'm a stress eater, right? So like I noticed, wow, my anxiety was more controlled. So I was really bummed because I ended up going off Zepbound initially because I did lose a little bit too much weight, went off of it. But then I was like, I need to go back on it because it helped my cholesterol so much. And when I went back on Zepbound, I don't know what happened. I was eating healthy. It just didn't tolerate really well for me the second time. It can?
Yeah.
Okay.
I mean, your tolerance can definitely change.
I'm pissed
and you're the
because I really liked it.
But you're the perfect example. And I love that you mentioned, like, it's okay. And I remind my patients this all the time. You never want to be like, willy-nilly with anything. It's like, it's especially with SSRIs. Think about that. Or blood pressure medication. You're on it or you're not, right?
Yeah.
Right.
Thyroid medication, Nicole, I almost passed away when she told me that she was being willy-nilly with it over the summer. With this type of use, if you're working with a clinician who truly understands how it is used and you're not using it for diabetes purposes, it is okay to cycle on safely, cycle off safely, right? Titrate your dose down appropriately. It sounds like you were just really sensitive to it. And that's why, why are we beating a dead horse? It's too much.
Right.
It's too much. So then I switched right over and I was completely fine. It was great. And I'm just doing 0.25 every other week.
Yeah, so that's even still like, and that's so important to mention too. Like, you're not a short guy, right? I know you have a smaller frame, but a lot of patients will tell me, well, I'm 350 pounds. I'm going to need a lot of medication. Absolutely. I have patients who can't get off that starter dose and they feel great and it's
They
working.
feel great and it's working. So why go up? If you're actively losing weight, don't, That was the issue, like in the beginning. People were so excited to get to that 15 milligrams of Zepbound. They wanted to get in the highest dose, but they were themselves, puking, having God knows what happened to them, right? I mean,
and
all
not
these
eating
side
at
effects.
all, right?
Not eating at all, losing muscle mass. And then, of
Mhm.
course, it's been a huge learning curve the past few years on these GLP-1s. And I think definitely this is what I say. This has been the year of the lips. We're going natural with the lips. This has been a year of people really getting more responsible and finding the right provider that's going to manage you better on your GLP-1s and your weight loss journey.
Absolutely.
And I think what's important to what you mentioned about aggressively shooting your dose up, like you said, losing muscle mass, losing hair. I always threaten that. It's a good threat. It's a nice threat. But then they stop it.
Like,
and then they stop. And they're like, well, it's too much, so I'm going to stop. And then they'll find out, they'll say, well, I just gained it all right back. And I'm not making fun. I think it's educational. For educational purposes, we need to educate these patients and explain if we're fixing a metabolic issue that you have, yes, it might have been done too aggressively. But if you have insulin resistance, if you look at all your family members and they have all similar metabolic issues, right? If you had gestational diabetes, if you've had issues with your weight, PCOS, most of your life, and you aggressively start and stop any way of dieting or managing weight, you're going to affect your metabolism and not in a good way. You're going to burn through muscle mass, but you also are potentially setting yourself up for failure when you stop it, right? And it might not ever be a good idea for someone to stop. You shouldn't be that high. You shouldn't feel, like crap. And I say to patients, you should not be able to tell that you're on this medication from a side effect standpoint. Yes, you should notice changes to food noise. Yes, you should notice that you just feel a little bit better or that you feel more full. You might have the occasional side effect if you're going to a wedding or a cocktail hour or you're traveling, and that's okay to skip it or to push it out a little bit or lower your dose. Like, it should feel like that versus this hard and fast start, stop, and then they wonder why their hair is falling out or they felt so tired or so nauseous. It should not be. And that is where this medication or this class of drugs got a bad name. And too much of anything is never a good thing. It's just like every other trend. It had to happen for us to learn from it.
Right.
I think.
Absolutely.
One question I want to ask, and I have one patient who was like convinced that what'd she say? That the compounded tirzepatide was stronger than the Zepbound. And when we converted over to Zepbound, right, when the whole compounded thing happened, we converted over to Novo Nordisk and, Lilly, all of that. We did that. And she just said, I just noticed it's just not the same. And I'm like, but it's the same drug. It's still it's tirzepatide that you're getting. But I wasn't sure if you noticed anything.
So theoretically, it's the same, and I'm so careful about explaining. You know how you have like acetaminophen and then you have Tylenol, right?
Yeah.
There's generics. There's a generic for a lot of our medications that are FDA approved. There is no actual generic for those. There is one, it's liraglutide, and that's an actual generic form of a brand name GL. It's an old, like one of our OGs. I think it's a daily injectable. I don't use it. But it's not a generic, but let's be honest, compounding pharmacies have chemists, right? They know what they're doing. They're still sourcing those ingredients from similar places and they're able to make the product, right? So theoretically, it should be the same, but some of them are salt forms, some of them are different forms, but they also sometimes have that other vitamin or amino acid or something else added to it, which for that patient may have been providing a synergistic effect. Some of it could be placebo. Some of it could be that she was injecting in a different spot, right? Belly versus inner thigh versus back of the arm. But I never say never. Like and I'm sure you guys obviously believed her, but sometimes you're trying to wrap your head around like, how is it possibly any different? I've heard it before too. And I don't ever tell the patient you're wrong.
My brain of science, I'm like, you're getting, it's the same drug. So for me, it has to be either where, like you said, where it was injected or, something like that. I had no idea. I have no idea.
But what's interesting that you say that is think about the patients, and Nicole, you might be able to speak to this. Think about patients that take Synthroid versus levothyroxine.
Yes.
Yeah, there are patients that swear, they'll say to me, like, my endocrinologist will not put me on, levothyroxine because I think it's
remember that in the
emerging.
hospital. People were so
And there's
gung-ho.
also, yes, and when I used to switch patients back when the compounding pharmacies were just starting to become a thing and really popular for GLP-1s, sometimes we would change pharmacies and patients would say the same thing, like, I swear I notice a difference. So I that is the one, like, blessing and curse with the compounds is they just don't have the same formula, right? They're not apples to apples across the board. They should be, but it's not necessarily. Where if you're getting Novo Nordisk product or, Eli Lilly product specific to them, you're going to get the same exact thing every single time. And so that's why I don't think that it's a hard or fast, good or bad. I think it's more what works for the patient, what makes the most sense for them. And I hear them out. And that's something I would document, right? If I were her.
What would you say, someone who comes in, and we get this all the time with Botox units, when they say like, oh, well, my friend got 34 units, so I should get 34 units. What do you say? Oh, my friend, I know I've been on Wegovy, but my friend's on Tirzepatide. She's lost way more weight. I think I should switch over to this. I think that's the better one. And to add on to that, can you explain to the audience like the difference between Wegovy versus Zepbound or semaglutide versus Tirzepatide, and how the GLP-1 and GIP, like all of that?
Yeah. So to back up, I think a lot of what I determine with the patient, unfortunately, but fortunately, comes down to cost. It comes down to what their insurance will cover. But ultimately, it comes down to what I think is best for the patient. If there's a family member connection, and I get a lot of mother-daughters, which I love, right? Not that they're coming in together. Sometimes they do, and that's fine. But I get a lot of that, hey, my mom is trying it. And the mom will start talking to me and say, hey, you know what? My daughter reminds me of myself. She's struggling in the same way. I want to help her more than how I was helped at her age. And it's very delicate, right? With younger women, of course. But 9 times out of 10, that daughter is agreeable to it and wants to come in and learn about it. If the mom really did well on one versus the other, I tend to put that patient on the same one, just because I find sometimes they have similar effects, or they feel similarly. But if it just comes down, if you just came in and you were like, tell me what you think is best, I usually would say, hey, if your insurance covers it, we'll go with whatever one is covered first. If insurance is not a concern and they're like, tell me what to take and I'll take it, I'm going towards Zepbound. And like I mentioned before, it's solely just because patients, like you, tend to do better on lower doses. And it activates the GLP and GIP. Now, that just has to do with what receptors are being activated and where they're located in the body. And the new ones that are coming out are actually activating 3 receptors. So there's more coming out down the pipeline. There's retatrutide. There's an oral version of Zepbound that's coming out from Eli Lilly. Actually, there's oral Wegovy that just dropped. So I don't want to call them guinea pigs, because we've had Rybelsus, right? We've had oral semaglutide at 14 milligrams. It's not new. Please, it is not new. But using oral Wegovy up to 25 milligrams is new. And we have to be so direct with that, right? This is not brand new information or brand new medication, but the application is different. And the reason why we have higher doses is because they're trying to make sure that the dose that's reached is tolerated, but it's also comparable to what's available in the injectable form. All right. And I could draw a little diagram, which I feel that I should, but you could branch off in a million different directions here, right? So now you've got injectable Wegovy, injectable Ozempic, same company, Novo Nordisk, oral Wegovy, right? All the same company, same active ingredient, different absorption, different FDA approval, different application. Mostly similar dosing pattern, but not necessarily for diabetes versus obesity. Then on the other end, you have my besties, Eli Lilly, and I'm not getting paid by them to say this, but I just tend to just vibe with them more. We've got right now just Mounjaro and Zepbound. And a lot of my appointments, half the time, go into just starting there. Like, hey, what are all these names? What do they all mean? Mounjaro's diabetes, Zepbound is obesity. Then you have this new oral version that's coming out. I was told end of Q1, but we'll see. And then you have these other medications like retatrutide that are still in trials. I just heard from another endocrinologist about another one that's an antibody, and it's a once-a-month injection. So it's a different science, like a different technology, but similar activation of these other receptors. So again, it's just and then you have, like I said, the old school liraglutide. It's just it's more, more options, like more fillers, more, toxins. Daxi came out and everybody was like, oh my God, 6 months. You start to walk that back when you actually start using it, and you realize some patients are a good candidate for that.
Some people are unicorns, and it does last 6 to 9 months, and some
and the rest are like me, and it doesn't.
Oh my God, stop it.
But you know those patients who
but she's also looking at people like that, like
you're willing to try it with certain patients, right? Because A, they're agreeable. B, they need a try of something different. I have a patient who, no matter what we do, she tries the Zepbound, sick as a dog. We had her on, compounded semaglutide. She was barely, she was at like half of the starter dose and was still so sensitive. I said, you know what? You're my perfect patient to try oral Wegovy, but just hopping on over into hormones. Guess what? She had a hysterectomy. I said, please, let's just talk about it. It is not, I never tout hormone therapy as the main driver of weight loss. But if you're still willing to try those GLP-1s, please, let's try to touch some of your other symptoms with something else, knowing you had that partial hysterectomy. She has 1 ovary. I'm like, it's not cutting it anymore. You're in your early 40s. Let's do both together and just try it. Nothing has to be this, you're on this for a year guaranteed. If it doesn't work, we'll switch you to something else. And that's what I love about these products coming out. What I don't love is we're sourcing it from places that are not appropriate, or we're diving in and just saying, I need that, but they're not changing their nutrition. They're not even understanding if they have insulin resistance to begin with. They don't have any direction as to why they're even using it. Jon, your reasoning was perfect. You had high cholesterol, right? So yeah, you're not morbidly obese. You never were. But it was okay to use it in the way that you did, knowing as an indirect benefit, it would help with your cholesterol. And that's what I think should be the takeaway, instead of advertising this as, you don't need to diet or exercise, just pay us for four doses a month, and you get the medication. Don't pay us for medication. Go to your GP if that's all you want, right?
And the one thing, and I mean, I was just talking about this at dinner with a friend last night who's also an injector, and she noticed she just had to go off of her GLP-1 for 2 months because she had just had a breast lift augmentation, and she's going to go back on it in a few weeks once she's like more, progressing and healing more, because, just so that way she gets her adequate protein intake. That's why they're telling her to remain off of it. So she heals right. But she's noticed, she's like, oh my God, I feel bloated again. I feel like when I was on it, I felt like my body was more like an hourglass. My face was less puffy. And that's something that I feel like over the past year, people tell me all the time, like, Jon, you just look so good. Like your face looks so good. Like you don't look, it's just like you're more like contoured and then like less like inflamed. I'm like, yeah, like, and like my pants feel better. Like I'm less bloated. I used to have to, after I ate, unbutton my fucking pants on the way home just so I could just so I can breathe. I eat a meal now and I don't have to do that. Like it's helped with food sensitivity. There's just so much that it does. And I just freaking love the medication so much. I feel like my rings fit better in my hands because I'm less inflamed.
Well, it's important you say that, because, and you guys are injectors, like this is all you have, right? I've heard, and none of this, like, asterisk this. This is not proven medical, right? No. We don't have this in studies, but anecdotal observational data, in my opinion, still matters. And as clinicians, this is what guides our clinical practice. You ask anybody, right? You know what works and what doesn't based on your experience. I've heard of improvements in joint pain, improvements with sleep, improvements with energy, improvements with, some patient was like, Megan, have you had anyone say that they have OCD, clinically diagnosed, and their thoughts have improved? And I said, you know what? No, but it makes sense to me. It does, because it all is connected to that thought process, right? And we know that it impacts that. So the bloating, the GI symptoms, patients, sometimes they have chronic idiopathic constipation and they're like, I'm terrified to do this because I'm afraid it's going to make me worse. I have had patients say that it's made them more regular, coming from both sides of the spectrum. Anyone with Crohn's, IBS, thyroid, Nicole, Hashimoto's, like, it can do all of those things. And again, if it's used correctly.
Have you heard of the GLP-1s or GIPs causing anxiety?
So there are some warnings if you look at the labeling about suicidal ideation and, thoughts of harm to others and yourself. You have to be mindful of that, because if we think about when you take away something like food noise, and I'm just being very general about this, patients have noticed, and they're definitely, there's starting to be conversations about it being used for alcohol use, right? Gambling, any addictive behaviors. When you take that away, you're calming what that person probably used as like a dopamine hit for a lot of their life. So I do see patients, especially with libido. I warn them. I say, if you're already coming into me with low libido and it's impacting your marriage or your partnership or your relationship, and now we're giving you something that might calm down some of that drive, we have to be so careful, right? Especially if we're toning down energy too, because we're not eating enough or we're not, moving our bodies. So I 1,000%, I do see that. Imagine someone that has a lot of side effects, a lot of vomiting, a lot of diarrhea, malabsorption. They're not getting enough nutrients, right? Not enough vitamin D, not enough ferritin, not enough iron stores, really. Those are all affecting your mood, right? So indirectly, you have to know that going into this. So maybe more
depression and like low libido potentially, but not as much maybe anxiety that you've been
Anxiety,
seeing?
I've had a couple patients tell me they've had tachycardia, like they've felt palpitations when they first started it. And that is actually a side effect that we know can happen. So I think it's really important, again, to educate about the time of the day.
Yeah. Do you think that has anything to do with like dehydration?
I don't, listen, yes, right? If Jon started taking it and he's vomiting, having diarrhea, or just not drinking or eating enough because he's not thinking about it, right? Like, yes. But if he's doing all the things and he's still getting that tachycardia, that is a known side effect. It's usually during initiation of therapy. But the worst thing you can do is tell someone, it's not from that. There's no way.
So much better.
Right.
Because
you feel like
when I switched over to Wegovy 3.5 months ago, I started having a little bit of like heart palpitations or whatever, and I gave it a few days and ended up resolving, and I haven't had it since, and my heart rate's always 60s, 70s.
Yeah, I do remember you telling me that.
And a lot of women and men with the Aura ring, they notice it. They'll tell me like my HRV has changed, my average heart rate has changed, and they don't even notice it. So
I literally went upstairs to check my blood pressure, and Corey's like, "What are you doing?" And I'm like, "Check my blood pressure. My heart is racing. I think I'm dying. Like, do I have a PE? Like, we had just traveled. I'm like, oh my God, like feeling, do I have calf pain? Do I have calf? And then he's like, you are crazy. And I checked and I'm like, my heart rate's 94. This is not normal for me.
This is not me.
But it's good to be aware of that. And I think the best
that's
way.
That's good to know.
Yeah. Right. And like, all kidding aside, not to sit here and sell ourselves even further, guess what? A patient who's checking in every month with their provider can get those validating that feedback, right? Versus someone who's like, I don't know, I take patients all the time who are seeing a regular clinic, like a regular insurance-based model doctor or practitioner, PA, NP, doesn't matter. And they're not given what I'm giving them. Or I'll get a lot of women who come in and say, my husband's using this and they don't hear or tell me about any of this. Can he see you? I'm like, absolutely. So a lot of them are already using the medication. But guess what? It's not just about the drug. It's about everything else that you can use to your benefit if you're informed. And is what that's what you're paying me for. You're not paying me for a prescription.
And that's what I love about you, is that you're well informed and you're so educated. Like other people might be offering, the services, and someone might ask that question and they don't know. Or they say, no, it doesn't cause that. And then they're like, they're still anxious. They're like, oh God, is something wrong with me? And then they'll go and they'll get all these tests. But really, like you said, initiation of therapy can sometimes cause a little heart palpitations, but usually, resolves over the next couple of months or whatever.
And it's okay if you don't know, right? As a clinician, like, we don't know everything.
But
and guess what? The only way I've learned this, is 100%. The only way I've learned this stuff is because it's all I do. I eat, sleep, drink, breathe, podcasts, you name it, all the time. But I had to find that community. Like, and Nicole and Mel hear me talk about this, and everyone who works at Exhibit. I don't have, a peer with me in the office. Obviously, someday I would love to grow to have that. But it's hard to find people that are doing what I'm doing. It's almost like you guys when you first started injecting. It's hard to find that community if you don't look for them. Had I not found them online and got my way into some of these mentorship courses and joined this community, I would feel very lost. And the only way to find these communities is looking for it, not just acting like a know-it-all and saying, well, there's no way, right? I had to look for these answers and also learn from my experience with patients. If they reported symptoms back, jotting them down and making
Mhm.
connections and saying, hey, I'm seeing this in a lot of patients. Like there's got to be a connection.
Right.
Mhm.
Yeah. Meg, I have 2 questions. Kind of
Sure.
going back to retatrutide you had brought up.
Sure.
And I'm sure a couple people listening might know who I'm talking about, but there's someone like a creator on TikTok who said that she was taking that and it was from, she's up and down. It was from a reputable physician, and she had really bad side effects on it, and whatever it may be. And I think it's important to just talk about, right? Like, even though she's seeing a reputable physician, again, it's not FDA approved, so we don't know where it's coming from. It's still in trials, and kind of like touching on that and other peptides,
Absolutely.
their safety and efficacy and all that.
Yeah. So I actually attended an A4M conference in September 2023. And what was beautiful about it was this is when peptides were still available via compounding pharmacies. So I was learning about, all these peptides for gut, for injectable, intranasal, oral peptides, right? Those are usually the 3 main ways. We were learning about PRF and hair restoration and under eye and skin rejuvenation and gut health and all these applications, right? And it was amazing. I was overwhelmed with information. I bought all the books, which I gave to Kevin. I'm like, this is just, wow, this is a lot. And how did we not learn about this in school? This is crazy. That weekend they made an announcement the FDA was pulling peptides from, approval. And it was mostly because they were noticing there were enough reported side effects and they realized there were not enough studies. So what's happening now is you're noticing that it's exploded again. I think part of it, and we're not getting political here, but the new administration did mention that they were going to list that as a priority, right? So obviously that brings things to the surface. What you're seeing now is some clinicians are still choosing to prescribe it, even if it's coming, as you said, from research-based sources. Compounding pharmacies who are willing to take the risk and still create them, or they're just using it from, they're going into that gray area and they're willing to provide it. And I don't really have a comment on whether or not that's the best thing for them. I think you have to look at your state guidelines, right? Your board of pharmacy, and all your different state guidelines for nursing practice as well, and make sure you see what's going on in your state for trials and what's happening legally. But I also think it's important to understand, are you actually optimizing the opportunity for that peptide to do what it's supposed to do, right? GLP-1s are peptides. Retatrutide is one of them. But there's other peptides out there like BPC, CJC, ipamorelin. I personally used to prescribe them because they were available and I saw that they worked, right? For tissue healing, tendon repair, gut repair. But the problem now is they're not technically allowed to prescribe. And that's something that you have to consult. Like we're so lucky to have Langia with us, but you have to be willing to talk to legal, a mentor, all the clinicians you're working with, and not only understand what they're doing, but really be confident that they're going to provide the benefits that you're touting, right? Having your consents in order and counseling the patient.
And
Most
checking
of my
with your
patients,
insurance company.
Yes, malpractice.
Yep.
And it's your responsibility as a provider to not advertise it as this magic juice. You're seeing it advertised as it's going to change your life. And then you talk to the patient, like, well, I still like to go out and drink 5 to 6 times a month, even once a week at this point.
Yep.
They're not going to the gym. They're not eating whole foods. It's okay. There's no judgment, but do not waste your money. These peptides can be very expensive, very unstable. Everyone's combining them to these stacks. You'll see stacks of like 3 to 5 peptides. Do we even know if those are now stable in that one vial? That's where, and these health coaches, again, nothing against them, but non-licensed providers right now, they're exploding because they don't have anything to lose and they can make claims and they don't get the same backlash that we would get as a clinician if we were to make certain claims, right? Because that's the license we signed. We have these agreements that we sign when we become providers and we provide prescriptions.
Have you had to deal with, I know in the injectables world, we've had to deal with a lot of patients. I hate saying deal, but we've had to address a lot of issues with people being scared of filler, that filler fear, making, they're scared that they're going to look fake or not like themselves. Have you had anybody coming in, fear mongering over these GLP-1s or hormone replacement therapy that you've had to talk them off a ledge, or maybe just, go over certain myths versus facts with them?
Absolutely. And just similar to you guys, remember, no one's coming in. We're not pulling these people off the street. Okay.
Right.
They are willingly coming in, but it is okay to have your qualms and things that are holding you back. And I think the fact that patients are willing to be honest with you guys in the chair means that they trust you and they're just looking for that support. So instead of us attacking them and saying, how could you say that? You know, they're looking for education. And I think that's right. It's a safe place. So I don't find, to be honest with you, I don't find it's happening as much with GLP-1s anymore because the media in a good way has really done a mostly decent job lately about
it shed a really good light on it.
Yeah. For a while there, like my parents were like, you know, you hear more about those GLP-1s and it's causing bowel perforations and pancreatitis and all the, and it's ruining fertility and
well, I remember Kevin went on it for his, he's pre-diabetic and we just cannot get his A1C down and he went on it for that. And I remember my mom finding out he was on it and she's like, why is he on that? He doesn't need to lose weight. Like, that's crazy. And I'm like, that's
and you're like, it's not for weight loss.
Right.
But,
and that's what I tell people about my cholesterol. They think, I'm like, guys, it's not. I'm not losing weight. I've stayed at 176.
Right.
It's shifted now. I don't want to call it fear, but the counseling I've noticed is now with my women very, very heavy on hormone therapy. And we could go on for 10 hours, which we're not going to do. But the moral of the story is
hormone therapy?
There's a lot of lack of education from your providers who are more experienced, myself included. When I came out, the education we received in our schooling did not match what's happening now. And it's due to the WHI. It's it's the study that was ended early, came out in 2001. If you actually read through the study, it was really to see if initiating hormone therapy would help prevent cardiac, like poor cardiac outcomes. So the intentions were great. They ended it early because when they pulled out some data prematurely, and there's a difference between absolute and relative risk, all you need to know is they hosted a press conference. They were like, we ended the study. It was causing breast cancer. It caused mass chaos. If you look at the study now and you actually understand how to interpret the statistics and the data, and they've rerun through this multiple times now, there were a lot of good outcomes that came from it with colon cancer and other cancers that it helped actually prevent. But you also have to look at the hormones that were used. They were using hormones that we really don't use anymore. They were not really using bioidenticals like we do now, right? And bioidenticals could be a whole other conversation, but all that matters is they're synthetic and there's ones that your body recognizes as identical. That's the main difference. They were using mostly synthetic hormones in that study. And they also didn't pick the correct study group. So they picked women who were already in their 70s and 60s and maybe already had other things that could increase their risk for breast cancer. Some had been on hormonal birth control for years. Others hadn't. They didn't really control the groups well enough, which is still now to this day causing a lot of fear and lack of, like courage in providers to prescribe it. And as soon as they hear family history of blood clots, family history of liver disease, family history of breast cancer, it's like they get a hard stop. And they're telling them, you're going to get breast cancer if you do that. I've had patients call me and say, Megan, my primary care doctor found out I was using a estrogen patch, which is bioidentical, transdermal, not going through the liver, not going through first pass metabolism, not changing risk for clot at all above baseline. She literally told her, you are going to get blood clots from that. Rip that off your leg now.
Yeah, it's
great. Not even bothering to try to talk to me. Yes. And so I do get those patients who have factor V Leiden, like have clotting risk, right? Or they have a family history of breast cancer, or they had a personal history of breast cancer. Hormones, again, just like everything else that we do, they're not black and white. There's so many tiers to what you can offer. There's vaginal estrogen that's localized. There's systemic hormones. There's synthetic hormones. There's pills, patches, sprays, pellets, don't get me started, but there's so many ways of delivering this medication or this hormone that can change your risk profile, but also your benefits. And you need to speak with someone who's aware of all this.
Yeah.
Let's talk about nicotine, because nicotine has been in the media.
Why do you want to talk about nicotine, Jon?
Well, because I've had a few patients that have come in with nicotine patches, and they're reading that it's actually helping to increase their cognitive function. There might be, I don't know if it's anecdotal studies or data that's showing that it's decreasing risk for dementia or Alzheimer's. It's helping with focus. So what do you have to say about that, Meg?
Not much. Only because personally it hasn't hit me yet. I don't want to speak on it if I haven't experienced it yet, but I also have seen that in some of the communities. But what I will say is, remember, decades ago, doctors were recommending smoking smoking cigarettes to their patients, right? So I'm not about to be out there yet recommending nicotine patches, but what I can say is the delivery route matters, right? A transdermal delivery versus you smoking something, completely different. So if they're making that connection between the benefits of nicotine and the fact that it's being delivered through a patch and they're not inhaling it, okay,
Well,
even the
who
nicker
is
is
that
gum,
doctor?
right?
Is it Dr. Peta Atea? Is that his name? Dr.
Atia, yes.
Atia, yeah. Because I think my husband watches a lot of his, podcasts and, a lot of his videos. And he just talked about nicotine. And he was saying, no, like, I don't recommend it all the time, but like, it's definitely not bad for you to go on a nicotine patch if you're looking for more focus. If you don't have anxiety, because nicotine is a stimulant, so it can increase, your anxiety symptoms or tremors or whatever you have. But if you don't have anxiety, but you're looking for more focus or more cognition clearing aspects, then consider going on it. And honestly, he said that are potential studies in the works that could show that it could help decrease Alzheimer's and dementia.
Wow.
I think, and this is an example of if someone came into me and we did their full consultation, because that's the way I start everyone. They come in, they do their blood work. It's a full panel. If they're not on birth control and they're not in menopause, I say, come in at a certain time of the month. Let's do your hormones along with everything else. And we'll do a deep dive, right? They come back, we review their labs. Now, if someone's complaining of what you just said, like the lack of focus, the brain fog, they're concerned about their Alzheimer's, dementia risk, and maybe they're concerned about their bones and their sleep and their anxiety and their mood, I'm going to make sure their hormones are optimized first. I'm going to ask, are you willing to talk about hormones? Because guess what? You're a great candidate. Maybe you're perimenopausal or maybe they're already menopausal. I'm going to go that way first, right? But I'm also going to talk about nutrition and supplements, not going crazy, but making sure they understand like, hey, we've identified in your labs, which are a snapshot of time, but we've still identified there are other things you can work on. I think you should try hormones too. Hey, maybe you have a little bit of insulin resistance. Do you want to try metformin? Do you want to try a GLP-1? Do you want to try low-dose naltrexone because you're feeling like you have inflammation and maybe a chronic autoimmune condition like a fibromyalgia, chronic pain? But if we do all of that and they're like, hey, I'm still finding I have, difficulty focusing and a lot of those other things, they want to try it, probably going to tell them, go ahead and give it a shot, give it some time. And if it makes you feel better, great. And if it doesn't, take it off. But that's why it's so important to work with someone who's following you along that journey. If you went to your GP and asked them that in one appointment, and then you don't see them again for like a sick visit or a year later or a cholesterol medication management, are you really going to be able to follow up with all these things? And is the provider honestly going to remember all that unless they have the time to write it all down? That's why the journey, I would be confident doing that because I'm going to see them every month for 6 months, and then I see them quarterly. So we do have the time to talk about those little things that are nice adjuncts. There's C-Link and C-Max that are intranasal peptides that used to be really good for those. Same thing. Was I going to throw C-Link or C-Max at someone without discussing anything else? No, because if their ferritin's at 6, they're iron deficient, right? Like they need that first, and then we're going to build on with those other things. So that's why, and patients do come into me with that all the time. They're like, Megan, you're going to hate me for asking this, but what do you think about this or that or NAD? I'm like, listen, if you're still out drinking or if you're not getting enough sleep and you're sleeping 5 hours a night or you're still smoking cigarettes, if you're doing other things we need to fix, do not ask me to put you on that. It's not, I want to get your cancer screening under control. If you're 60 and you haven't had a colonoscopy, turn your butt right around and we're going there first before we dive into shooting NAD in your arm. It's all, and that's our job to do that.
And I think it's important too, like, again, seeing a clinician like you instead of a your normal physical or things like that, because I think if you were to bring up that question about like a nicotine patch, they probably would just kind of laugh it off, whereas someone like Megan would take the time to really be like, what, let me look into this. There's some research behind it. Like, let's just see, let's optimize other things first. And then maybe we can go that route.
That's a really good point though you made about NAD and, like you said, like if you have to look at their age and make sure that they've gotten all their screenings done to make sure that, their cancer risk is lower, they're cancer free, right? Or make sure their lab work is all good before starting them on NAD, because as we know, NAD it fuels your mitochondrial cells, right? So it can stimulate new good cells, right? Growth. It's growth of anything, right? Good cells and bad cells, right?
Right.
Same with peptides. They literally stimulate growth. So that's, again, patients are like, I want to try CJC Apomorelin, or I want to try Smorelin. It's like, okay, but are your screenings under lock? Like, are you engaging in other activities that do increase your baseline cancer risk? That's really important. And I think the other thing to capitalize on, what we talked about optimizing everything else, is building a referral network. I don't do everything. I am not a one size fits all. If someone's mental health is in the toilet, I have a mental health, a therapist that I tend to refer out to. I have a network that I joined in the fall, which was super exciting. I worked with the physical therapist personally for my daughter, and they formed a collaborative network. So now I can refer out and say, work on this at the same time. I cannot provide therapy for you, right? Like mental health therapy. I might not be able to provide pelvic floor therapy, but I know someone who does. And we can work together to achieve that common goal, instead of you getting sent out with a list of referrals, at the end of your appointment, and there's no conversation about what they can do for you. So everything should be built upon, I know you guys do the whole cake analogy, right? It's not just filler. It's not just Botox. It's not just skincare. There's a reason why you guys refer to your estheticians for certain things, right? Because everybody plays a part in making you who you are, and it should be the same internally. I refer patients back to GIs sometimes. Yeah, there might not be functional medicine GIs that I'm referring to, or oncologists or hematologists, but they still play a part. I say, you need to get these things addressed first. I can still work with you. I hope they're on board with what I'm offering. If they're not, it's still your decision, right? It's informed consent, and it should be shared decision making. So I hate to feel like with hormones especially, there's this like, I'm against the surgeons, I'm against the OBGYNs. I'm not. I'm just willing to really go into it, and they might not be. And if they do get pushback, I say to the patient, hey, here's some guidelines. Bring it with you to your next appointment. And it's not in a nasty way. I give them my card. Call me. It should be shared decision making, but trust the person. Yeah, trust the person that this is all I do. So I go to the conferences. I'm in the mentorship groups. I follow the practitioners that are doing this all day, every day. Instead of, hitting up an influencer that has an MLM affiliate to a peptide company. It's scary.
Yes,
it is
it's
scary.
so true.
Especially some of these influencers, or I don't know, I don't want to name names, but there's just one recently that just literally shared that she's doing that. Like, she owns her own med spa, but then she's partnering with like a company that has doctors, and you could purchase peptides through this doctor. And I'm like, I'm like,
but what's scary is that company, and they've reached out to all of us. They're trying to tell these non-clinicians that there's zero risk associated, because they're not the ones directly supplying it. They're even trying to pull in clinicians to
really
say,
scary.
Hey, we're connecting the patient with a doctor. There's zero risk associated with what you're doing. I'm still referring that patient to someone, right? So it's a trust thing. And again, as clinicians, it just seems like we have a lot more to lose. I think I'll be just fine doing what I'm doing, consulting with legal as needed, consulting with my medical director and my peers. What's great about Mel and Nicole is they're not in this field, but they have the experience in being solo providers, and they have a network too. So the more that we work with each other as opposed to against each other, I try to reach out and network with my local OBGYNs, and like I said, my pelvic floor PT that I referred to, and my therapist. Moms are a great network, and
they are.
I go on these mom groups on Facebook sometimes, and I do look and see who they're talking up and who they're not talking up, because you have to work with reputable people, not people that just see dollar signs. And for us, sometimes charging cash, we appear to be greedy. We're really not. We're just trying to provide better care than if you did try to go through some of the older models of care. And I try to hit that home. Sometimes it's hard before I meet a person, but once I do, they're like, oh, she's just, she wants to be thorough and wants to chit chat for an hour instead of 20 minutes. Right.
Yeah. Which is so important. Well, this was great, Meg.
This was amazing.
Yes,
what a great episode.
Very informative. And I just wanted to hit, like, before we close out, like, you also, there's so much you can do just looking at a panel of labs. And even myself, right? I don't take hormones. I have not done a GLP-1, but I've worked with Meg so closely, and she's taken care of my thyroid, and she's optimized my vitamin D levels and iron and all these things that could play a role in making you feel foggy and tired. And there's a lot of other, I guess, I don't know, more holistic or just vitamin-based things you could be doing.
Yeah. It's things that you can do at home. And that's where I also remind patients, you don't have to work with me for a prescription. And that's where I kind of built out this primary care. Jon, I have like a 3-tiered primary care program now where my healthy men and women who maybe don't need medication or prescriptions, but they want the occasional sick visit. They want to do their labs quarterly or every, twice a year and see
actually
how the vitamins
understand
are.
the labs, right? Actually understand them.
Yeah. I still think there's a need for that too. And that's kind of why I built that out where they don't have to feel like, well, Megan, if I don't need a prescription, how do I work with you again? That was a big question I kept getting. Can you be my primary care? I mean, technically, yes, but I don't have the infrastructure right now. I didn't build it. So what did we do? We built it, right? Yeah. And the other exciting things coming is, and you guys are big proponents of this, is I would love to educate further and just provide mentorship to other clinicians.
Can I do a virtual?
Yeah, absolutely.
I'm licensed in New York.
She's licensed in New York. Yeah.
Yes. Oh my God, that's so cool.
Yeah.
Oh my God, I would love to do that Rupa thing. And the Rupa thing. I'm sounding so... I would love
clinical.
You're so clinical I'm sounding, but I would love to do my Rupa lab work. And learn more.
That's
and
what we
talk
did with
more
mine.
with you. Because I'm not going to lie to you, like I take those vitamins from that company. What's it called?
Yeah, the pure encapsulations.
Pure encapsulations, and I'm doing the men's formula. But I'll be honest with you, like it would be nice to kind of just get a whole list of like anything that I'm low on, and maybe I don't need to be on some of these things. You know what I'm saying? Like, what if I have iron overload?
No, and it's a possibility.
What is it called? Hemochromatosis? I don't know. What if I have something like that and I'm taking iron and I don't need it?
Even my out-of-state patients, I've had a lot of patients reach out to me from listening to you guys and just from meeting me through social media, and they're like, can you work with me even though I'm out of your states that you're licensed in? I can provide educational calls, which I also now offer that, right? So there's no prescribing, no official medical anything, right? No labs, no nothing, but giving them that direction. I have a referral network now because of some of the programs I've been a part of. That's important. But I do think just doing what you just said sometimes is so beneficial to patients. And then they know what they're working with and they don't need to feel, that's why telehealth is great.
I get anxious because I see some of these people that look so amazing and they're on these supplements and I'm like, I need to go on CMOS. I need to go on this. And then I like start it and I'm like, wait, should I be on this? Or
well, the colostrum has just taken the colostrum, the collagen,
the Armra, that gave me diarrhea. Like I could not deal with it. Like I clearly have like
stomach has been through a lot.
Yeah, it really has.
It's not well. I clearly have
beauty.
I have some gut food stuff, and Corey says it all the time. He's like, "You have food."
Do our gut test. That's another thing.
No, I want the gut and I want the
sensitivity. Yes, yep. And I'm telling you guys, like we really, if you're looking for something like that, like getting supplements that are tailored to you, knowing what's going on with your body, also looking at the gut. But even for me, and what we're going to close in a second here, but like migraine prevention, like I've been dealing with these migraines postpartum, and Megan's been able to look at my hormones and kind of we're kind of trying to figure out what might be triggering them. And there's so much you can do that's not just GLP and weight loss and things like that. So it's a really exciting time.
Yeah, it's not like, okay, Nicole, well, I'll see you in 20 years when your periods are gone, like 40 years. Like there is no hard and fast. If they can hand you a birth control pill, then we have the right to talk about hormones and what they're doing. So especially postpartum.
Meg, where can people find you?
So I changed with my rebrand. I am no longer Meg Aesthetic because your girl is not doing personally anything aesthetic to my own face. God forbid I have time to do that. But also I just don't offer laser and Botox anymore. So I'm Megan Piersanti _NP on Instagram. I am hopefully coming out with a Patreon soon. I would
that's
love
really
to provide
exciting.
Mentorship that way, just with like things that I think are day to day, but are really beneficial, right? But I also want to start offering, in-person shadowing. So really it's all through my Instagram.
That's huge.
But
and please let us know when you have your Patreon. And
I told her,
promote the shit out of that.
She's making it before Tuesday. So when this goes up, she'll have a Patreon, right,
That's
Megan?
amazing.
Thank God for this snow. I mean, the amount of people that ask me, and you guys know it has to be a passion, right? This is not, I'm not a millionaire. We're not making millionaires out of us, but we want to help people and we want to do it correctly and niche down. I can tell you how to do that because it happened. Here I am.
Yep. With a beautiful program. Well, thank you so much, Megan.
Thanks
you
for having me,
guys. And thank you guys for tuning. Yes.
Jon, if you don't do the fit test this time, I'm not going to forget.
Okay. I will do it.
Wait, we should do.
Thank
let's
you.
do it, and we'll do an episode going over your lab work.
No, that would actually be really
Right?
great.
We should do that.
I think it's going to be eye-opening. Oh, I just watched my husband leave. Where is he going?
Oh no!
You could do it.
In
We
this
can have
snowstorm?
him do it right from home. We can mail it to his house. He can
Okay,
get a
great.
little
I will do
finger
it all.
stick.
All right, we'll
Yep.
send it to you Tuesday.
Yep, great. I will send you my address. Guys, thank you so much for tuning into this week's episode of the Fill Me In podcast with Meg, the Wellness NP. We're so happy that you came on. Until next time.
Bye.
Bye.
All I want